Thanks, Ralph, for that very kind introduction. And I'd like to just extend a thanks to the organizer of the conference for inviting me to be here. It's actually quite nice to be back in the US and to be back at a meeting around HIV and AIDS. I actually started my first public health job was as a health educator and a counselor for VCT services way back when in Seattle, Washington. So I have some recollection of what some of the issues are related to HIV are. What I'd like to do today is actually shift the focus is to talk more broadly about implementation research and what that means to us, what that means to the World Health Organization, and how we're approaching that, and also some of the ways in which we're thinking about these issues and how to make it more useful. I think you've already heard this morning from the morning session that this is clearly an important issue. There is a need for that, for implementation science or research, and that we know that there's a lot of things to be happy about in terms of what the research has already done for us, and I apologize, I did not follow that. And I won't belabor the point of making the case for implementation research. I think what I want to talk about, though, is that while we all agree that implementation science is important, I think we have different viewpoints about how best to do that. And I don't want to add to the confusion about what is implementation research, what is implementation science, and so I will not offer a definition to that. But what I would like to do is present a different way of thinking about implementation research, and as the title of my talks is called Implementation Research as a Collaborative Endeavor, what I'd like to make the case for is that implementation science is just as much about the science parts of it in terms of whether you want to apply management sciences or health sciences, or it's just as much about those things as it is about relationship building and making sure that there's collaborations. I think the first speaker today talked about the importance of people, and I think that's what I would like to bring this back to, is focusing implementation science on the people and building the relationships with people. So I'll skip these first couple of slides, as I think they've already been talked about. But I wanted to take a step back and share with you an experience I had a few months ago, actually just last month. I was invited to a meeting in London, or at least I thought it was in London anyway when I accepted. So, and I had a bit of a hectic schedule, so I just, said yes, I'll be happy to go, and everything was booked. And I got to London Heathrow, that was where my flight flew into. And I got there, and there was a person waiting for me, a taxi driver, and he said, okay, we're going to go to Croydon. And I said, pardon? And he said, we're going to Croydon. I said, well, where exactly is Croydon? Well, it turns out that Croydon is a bit of I don't know why this is not showing up, a trek from London Heathrow, and it's actually about an hour drive away from London. So this taxi driver was actually very nice, and he was really chatty. So I like to talk to taxi drivers. So I sat and talked with him for nearly an hour, and what he actually told me was the history about how he was studying to become a London cabbie. And I don't know how many of you know what it takes to become a London cabbie, but apparently there's a whole process called London Knowledge. And it takes, on average, 3 years for taxi drivers to pass this certification. And what they actually go through is a very intensive process of not only understanding the routes, but what he told me was that as part of the testing, they don't just ask them, how do you get from here to here? They ask them, well, how do you get from here to here, and what happens if there is a traffic jam, and if you get blocked there, where would you go? How would you do this? And what if there's a construction? And so it occurred to me that, wow, that's actually really interesting that they're actually training people to be so responsive to real-world settings. Obviously, it's easy enough to memorize a pathway and to figure out what is the best way of getting somewhere. What is less easy and perhaps more difficult is actually thinking about how do you become responsive to changing environments, and how do you become responsive and adaptable to real-world settings. And it occurred to me that really that was what implementation science is all about. And that's why I shared this example. And when I got back to, when I finally got to Croydon, it occurred to me that, wow, this is really what we're talking about. It's not that different. I think that Stefano used the example of mozzarella and pumpkin spice lattes. But I also think that, I think that what we're really talking about is not just about identifying one single pathway. It's about understanding how to strengthen systems. And in this case, we're talking about health systems, and strengthening their ability to respond and adapt to different contexts and to changing contexts. whether that means incorporating new interventions or whether that means responding to a changing demographic. I think that's what implementation science is about, and I think that is the challenge that we have before us. You know, I took this, actually, this came from that meeting that I went to, and it was from the conference proceedings, and somebody actually said, what implementers do is really hard, and designing studies is not the same as designing programs. And this resonated with me because, you know, much of the discussions that we're talking about before the break was about how do you ensure sustainability? How do you ensure country ownership of these things after PEP4 money or whatever other programs run out? And how do you think about transitioning, and how do you think about those kinds of issues? And I think those are very difficult issues that are difficult to capture in the context of a single study or a single dimension study. And I think that the conversation that we had earlier about thinking about diverse numbers of studies is particularly pertinent to that. The second point that I think we heard this morning is that implementation is a process, is iterative and dynamic. And I think, again, Ralph was the one that showed the cycle of the mini cycles in terms of how decisions are made and how to improve upon decisions. And I think this is because health systems are dynamic and continually changing and also have to respond to changing demographics and to the changing populations that they serve. So I think we've talked about, I think where we are is that I think we agree that implementation science is important. I think we agree that implementation research is important to helping us understand real-world challenges and understanding the interface between what is possible in theory and actually what happens in practice. And I think the research should focus on strategies that are related to the delivery of services, delivery of interventions, and that we need to focus on the processes of implementation and the factors that influence those processes. But I want to just take a minute and reflect on what we actually are trying to do. And I want to just think about, you know, the terms that we've used historically and why we've shifted from those terms. I think, you know, we are moving increasingly from using the terms evidence-based to evidence-informed decision-making. And I think there's a reason for that. And I think if you think back to the example of the cab drive that I had from Heathrow to Croydon, I think what I got from that situation is that, you know, the decision to go a certain route, you know, from the airport to Croydon is not just based on what is the shortest distance there. It's based on my preferences as a customer, what I want to go, what I want to see, if I prefer the auto route or if I prefer that. Alternatively, I could have taken the subway. So I think when we think about the role of research, and in particular implementation research, in informing processes and informing scale-up or implementation, I think we need to also think about it as in terms of the role that it is playing. And I think that the role that it's playing is informing those processes. And I think it's really trying to assist and stimulate the decision making. And what I mean by that is that I don't think that it's always going to be the case. And I'm actually thinking that, you know, I wonder if how many studies there are that actually show that, you know, a study of implementation actually resulted in implementation exactly as the study suggested in any particular context. I think in most instances, even when we do the best implementation research, what actually gets done and how it gets done is often different because of the fact that we are not able to capture unintended consequences. We're not able to capture the impacts to the system if you try to integrate an intervention into the system. So for me, as I said before, I think what I think the role of implementation research and implementation science is to really build the capacity of programs, health systems, to be responsive to the needs of the environment in which it's working. I put this slide in, this is from Phil Davies' research, and because again, to think about the point about, you know, what we're trying to do. And as you can see, this is a slide that shows, you know, decision makers' preferences for sources of evidence. And research evidence is number 9. And I don't put this up here to
evidence is number 8.
Exactly, Cabby's evidence, street evidence. But I think we should also look and see that there is expert evidence. Obviously, expert evidence is sometimes informed by research. There's media evidence, there's internet evidence, there's lay evidence. And I think I'm putting it up here to illustrate a point that I think it's somewhat overly simplistic to assume that evidence gets translated into action and that it's a linear process. And in fact, I would actually argue that it rarely happens that way, that somehow evidence gets translated and then gets done, turns into action. And because of a number of reasons, and one of the reasons I think is that there are other things that decision makers need to take into consideration. And when I say decision makers, I mean policymakers, I mean implementers, but I also mean consumers of healthcare. So there is the tacit knowledge of those people in terms of what they know, what their instincts tell them, but there are also contextual factors that interact, and I use the word interact with evidence. And I think what our problem has been is that historically, we as researchers, and I say this having spent 10 years at an academic institution in Baltimore, that we have tried to sort of minimize the value of tacit evidence, tacit knowledge. And what our sort of aim has always been to say that we should use evidence over tacit knowledge. And we've not thought about it as an interactive process. And I think what more and more what we're realizing is that it's not a linear process, and it's not about putting into competition, is tacit knowledge better than research knowledge? It's about understanding how the tacit knowledge of the decision makers interacts with the research evidence, and how that actually informs the final decision. And again, if you think about that in terms of what I had learned when I first started doing public health work as a HIV counselor, was that we have to think about client-centered counseling, and what we were taught was always to think about not telling patients or clients that came in what we thought they ought to do, but actually asking them about what their preferences were and how they might be able to adopt this particular solution that we were presenting to them. And in fact, the outcomes of those things were often different than what we had in mind. And I think in some ways that ought to be how we think about implementation, is thinking about that we have something that's known to work, but that it's an interactive process, that implementation is not a linear process, it is an interactive process. And what we really want to do is to optimize what tacit knowledge brings into that. So, I just, because we're talking about evidence, and we had a discussion earlier about what constitutes good evidence, what types of evidence we want. I don't know how many of you know this gentleman. His name is Ignacio Vice, and he's actually a German-born Hungarian obstetrician that practiced in 1850s. He actually died in 1865 in a mental institution because of the fact that he was advocating that doctors should wash their hands. He was one of the first physicians, obstetricians, that had observed that sepsis was a cause of mortality, and that perhaps hand washing could be a solution to that. The point I'm making here is that this was at that time considered unscientific, and this was not proven by large-scale randomized studies. And again, I'm not trying to dismiss the value of those types of studies. What I'm trying to raise here is that there is a role for tacit knowledge, and that we shouldn't necessarily, because it is not research evidence, dismiss it as being not valuable, and that we should also think about how it actually can help the decision-making process. So I think the challenge, then the challenge for us is to think about how do we actually do implementation research. And I think the first thing that we often say is that we need to ensure that the right questions are being asked, and that these questions are based on real-world settings, and that they're responding to complex adaptive systems. And again, I think that this is because when we think about what health systems are, on the one hand, health systems are machine-like organizations, but on the other hand, they are complex and social political phenomena. And to understand those things, that we need a whole range of scientific methods. And I think this is why we have put forward this sort of thinking, that implementation research, rather than defining it in terms of clearly laying out what the boundaries are, we think about it as a continuum, and think about it in terms of levels and degrees of relevance to implementation science. And as you can see, as you move across the continuum, the questions become increasingly relevant to implementation, but that there's no single boundary that says this is implementation research and this is not. But I think the more important point for me is that for implementation research to do what we want it to do, that we really need to have the engagement of implementers. And that implementation research is more likely and to be useful where implementers have played a part in the identification, the design, and conduct of research. And that often, I think this is related to the point that Steph has said earlier, is that the people in the field, and it's related to the point about the importance of local data, that actually have an understanding of what the issues are. And I think it's important to be able to engage those insights as we're thinking about what type of research needs to be done, and how those insights can be brought into the research process. and that leads to me the point that what we're really saying is that we need to then embed knowledge generation within program activities as part of learning health systems. And what we really mean by that is that research cannot be done in isolation of programs, and it may be appropriate, an appropriate model when we're talking about biomedical sciences, but when we're talking more about implementation and health systems research, we really need to think about it as sort of a collective process. And I think what we have here is just a kind of a very sort of simplified framework in terms of thinking about how this might happen. And I think what we're saying is that there needs to be a resource team that you can't have implementation without the science or the research, but you also can't have the research without the implementers. And that you really need both to be able to do good implementation, to have good implementation science, and that there needs to be capacities for both, but also that we need to think about the institutional arrangements and incentives that support these. The question that I actually wanted to ask earlier before the break that I didn't ask was that, there was a lot of discussion about, how do we bring about changes in the way that we think about implementation research, and how do we think about the range of studies that ought to be funded. And the thought that was going through my mind was that, we have the exact same discussions at WHO, and one of our questions is, how do we hold, and this is a very racy thing to say in front of a room full of researchers, is how do we hold researchers accountable for the products of their research? There's a lot of discourse about, policymakers, decision makers, and implementers not regarding evidence and not paying enough attention to the evidence. But there's very little discourse about how that research evidence is generated, how relevant it is to the problems, and why it is conducted the way it is. I mean, we know that we work in environments that have a lot of pressures in terms of publish or perish, and we know that there is a bias towards different types of studies, but I have rarely had a lot of discussions, been engaged in discussions where we have been able to talk openly about how do we change that system? And to me, that it's not useful to think about changing mindsets or changing frameworks for how we do research unless we're able to talk about the incentives for researchers as well in terms of how they get funded for research, how they get promoted. And again, I say this from having spent several years at a research institution, so I'm not in any way trying to demonize researchers, but I think this is an important consideration that we need to think about. So I think the point that I want to make here is that implementation research, one of its role actually, in my opinion, is actually transformative. I don't like the word translational research simply because it assumes a sort of a linear process, and it assumes that what we're trying to do is we're trying to translate research findings into actions. And as I said before, I think what we ought to be thinking about is how do we transform research evidence through an interactive, iterative process that takes into consideration tacit knowledge, that takes into consideration societal preferences and contextual factors, and transform that into actions that are useful and relevant to the populations that they're intended to serve. So I prefer to think of implementation research as not translational research, but as transformative research. And I know that's a question of semantics, but I think it's an important distinction for me. And I think that's why we think of implementation research as something that ought to be embedded within the context of health systems, and that should be embedded within the context of health programs. There are a number of examples, and I don't want to go through all of these, but we did, by the way, just put forward, and I think there's a publication outside, you'll see that. And some of these examples are all from this guide that was just released 2 weeks ago at WHO, which is called the Guide, Implementation Research, a Practical Guide. And we have gone through a number of examples, and for example, this example comes from Afghanistan, and it's actually describes the use of the balanced scorecard. I think this is a very simple example of how implementation research builds upon existing and routine data systems, and that it was used to monitor progress, but it also stimulated then changes within the system that resulted in the improvements that you see there. Another example that we highlight in the guide is the use of quality improvement studies to improve screening and follow-up for cervical cancer. And as you can see, in Ecuador, there was a study that was done, and they used 4 cycles of Plan, Do, Study, Act. and they actually had quite a lot of improvement. The other example that we talk about in this guide is looking at how implementation research can be used to inform scale-up and what that means for the research process. And this is an example from Malaysia where the study was actually done in collaboration with the Department of Road Safety, and they actually scaled up an intervention to improve visibility of motorcycles at night. I think that, again, as we're thinking about, if you accept my sort of hypothesis or my thesis that implementation research really needs to be embedded as a core function of programs or health systems, then I think we need to think about the funding for research. And this is the question that I wanted to ask earlier, because we don't have the answers to this, is that how do we actually use funding to leverage, the types of changes that we want to bring about? And that there needs to also be a systematic application of research and scientific inquiry within the program activities itself, and that the programs also have to change. That it's not just a matter of saying that researchers need to change the way they do that, but programs and the way that we think about programming also needs to include the research. And then finally, I think there's a need to discuss the shared responsibility for decision making. I think it's too easy to simply say that, well, these decisions weren't made based on evidence. And I think we need to start thinking about what is the role of researchers in that decision making process, and what is the accountability that researchers should have in terms of whether or not dealing with the fact that the evidence isn't used. Is it because it was completely disregarded, or is it because it's not relevant, or it wasn't used for, it wasn't timely? And I think it's easy enough to say that evidence wasn't timely because it's a different process, but I think as we're thinking now about implementation, I think these are issues that we need to be able to respond to. So I think that, the last few slides is that, I think what I want to say is that implementation research and this idea of collaborative research is not easy, and that there are a number of factors that we have to think about, including the incentives. But that I think that this is, rather than offering you a definition, I think what I want to say is that implementation research is collaborative research. And until we sort of change our mindsets and think about it as a collaborative product and process, I think we are still going to be missing many critical insights that we need to think about. As I said, these are two publications that we have recently developed over the last 2 years. One is called Changing Mindsets, and it's actually the WHO's first strategy on health policy and systems research. And it talks about some of the issues that I've raised today in terms of thinking about how one should engage with decision makers, what is the role of research, and what is the dynamic that we ought to be striving for. And the other is this guide, practical guide for implementation research, that talks more about the types of issues that I've just raised this morning. So I'll end there. Thanks.
Thank you.